Good evening, everyone.
Yeah, good evening.
So, today's the topic is neurological disorders, and the speaker that we have here today is Dr. Varun Pushkarna, who is Senior Consultant in Internal Medical Fortis Escortis Hospital, Amritsar. Thank you, sir. So, you may start now.
Yeah. So we'll be discussing the EDIC neurosciences, and it is an amazing topic and almost covers around 30% of the syllabus for EDIC. So we will just first brush upon the most important topics, the key points. You can take snapshots for these because these are the mandatory ones that you need to know for the exam. So the key topics from neuroanatomy and physiology would be blood supply to the brain, taking in consideration the circle of Willis and its autoregulation. Cerebral perfusion pressure. You will have at least one or two questions from this topic, cerebral perfusion pressure, which actually is calculated with mean arterial pressure minus the intracerebral pressure, and the regulation of ICP and Monroe Kelly doctrine. We'll go into it. Brainstem reflexes and neurological examination in the ICU. Pathways in the spinal cord, both motor and sensory tracts, along with CSF production and its circulation. So these are very important topics. You should brush them very thoroughly. Then comes the neurocritical care part, in which mainly five topics are there, which are asked time and again, and no matter what stem they start with, they eventually end up discussing these topics. One is the management of intracerebral pressure in traumatic brain injury, and then the strokes. So, ischemic versus hemorrhagic, both of them, and their considerations in the critical care. Then, status epilepticus. I mean, normal seizures are not the ambit of critical care, it is the status epilepticus, its management and the drug therapy. Then, the criteria to diagnose brain death, the confirmation of it, and how to proceed about it. Then these days, a lot of questions are being asked from induced hypothermia, temperature control for neuroprotection, sedation, and of course, ventilation. So these are the core topics of the neurocritical care. Uh, Obviously, what happens is when people are preparing for EDIC, they are usually preparing more for the neurocritical part, but they're ignoring the physiology and the pharmacology. So the pharmacology is the next topic, which includes the drugs which are required and are given for sedation in a neuro ICU, including the famous drugs propofol, dexmedetomidine, and benzodiazepines. Then the anti-epileptic drugs and their use in the ICU. Then osmotic therapy like mannitol, glycerol, hypertonic saline, their use in raised ICP. Then the use of vasopressors and autoregulation in the neuro ICU. All right. So we will begin with the topics and MCQs because that is the crux where we all have to land up on. So we'll just discuss these topics, and then eventually we will venture into the clinical scenario. So we have a 55-year-old male who is admitted with a severe traumatic brain injury. His ICP is 28 millimeters of mercury and MAP is 80. So, what is the cerebral perfusion pressure and what is the target range in traumatic brain injury? Anyone? So, this is a topic of traumatic brain injury and the management of cerebral perfusion pressure. I understand you guys are preparing for EDIC, so you must be ready for a question like this. So, can anyone answer this? So, what is the CPP here? So CPP basically is, as I told you, MAP minus ICP. So MAP is 80 and minus 28. So what we get is 52 millimeters of mercury. So at least we get one of the half answer correct. That is 52 millimeters of mercury. So the Brain Trauma Foundation, that is the BTF, it has issued guidelines that recommend that a CPP should be maintained around, anyone, 60 to 70 millimeters of mercury. So this is mandatory information for all the people who are appearing in EDIC. To prevent, why do we need so much of CPP? Anyone? Why do we need a CPP of 60 to 70? So that the blood could flow through the swollen brain and nourish the cerebral areas. So as to avoid ischemic injury, and also to avoid excessive perfusion also at the same time, so that it doesn't cause unnecessary edema because of the high perfusion pressure. Everybody got this question? Yes, you can contribute, because as I
Yes.
progress, it will become an more of an interactive session and lesser of a one-sided knowledge gathering. Okay, so what have we gathered from this? Number one, that the formula for calculating CPP is MAP minus ICP. And the second is that as per the BTF guidelines, Brain Trauma Foundation, the CPP has to be kept between a narrow range of 60 to 70 mm of mercury to avoid both ischemia and excessive perfusion leading to cerebral edema. So the answer is correct. Map the 52. So this is the target CPP has to be around 60 to 70 millimeters of mercury to avoid secondary ischemia and avoid excessive perfusion that could worsen the cerebral edema. Which of the following is true regarding the blood-brain barrier? Number one, it allows large hydrophilic molecules to pass easily. Number two, it is disrupted in conditions like meningitis and stroke. Number three, it prevents passive diffusion of lipophilic drugs. And number four, it is primarily maintained by astrocytes and Schwann cells. So which of these are true for the blood-brain barrier? So blood-brain barrier is made by which type of cells? Anyone? So blood-brain barrier is basically formed by the tight junctions of endothelial cells, okay, and they are maintained by the pericytes and the astrocytes, okay. So these are the junctions which are protected by the pericytes and the astrocytes. So astrocytes is correct, but Schwann cells is not. So there has to be pericytes to make this answer correct. So that means this answer is wrong. Okay. It allows large hydrophilic molecules to pass easily, when actually it allows only lipophilic molecules to pass. So hydrophilic molecules that do not pass easily, they are passing with difficulty. So true, the good brain barrier will not allow the hydrophilic molecules to pass. And then it is disrupted in conditions like meningitis and stroke. This is correct. It prevents passive diffusion of lipophilic drugs. When I just told you that it basically is meant to allow the lipophilic drugs to pass through. So this is also wrong, that it does not prevent, is it assists. So the only correct answer we have here is it is disrupted in conditions like meningitis and stroke. So what have we gathered from this? That the typical blood-brain barrier, it is basically made in the tight junctions of endothelial cells, and it is made by astrocytes and pericytes. It does not allow hydrophilic cells molecules to pass through, but for lipophilic it allows to pass through. So the answer correct is disrupted in conditions like meningitis and stroke. So it is a selective barrier which is formed by the endothelial cells tight junctions maintained by astrocytes and pericytes. It prevents the hydrophilic molecules, but it allows the lipophilic molecules. In conditions like stroke, meningitis, and trauma, the blood-brain barrier becomes leaky, leading to vasogenic edema. Okay. A 40-year-old man with subarachnoid hemorrhage is in the ICU. Nimodipine is administered to prevent which of the following complications? Rebleeding, hydrocephalus, vasospasm, or seizures? It is a very easy question. I think everybody can answer that. So what is the answer? Yeah, so the answer is vasospasm. So basically, nimodipine is a calcium channel blocker. It is a CCB. It reduces vasospasm. And what is the most common time for vasospasm to happen?
Day 4 to day 10.
So it is most common between 3rd to 14th day post-operative. So day 3 to day 14. So nimodipine is very, very effective. Nimodipine reduces vasospasm. It is a dihydropyridine category calcium channel blocker. It reduces the risk of cerebral vasospasm that occurs usually 3 to 14 days post SAH. It does not prevent rebleeding, but improves the outcomes by enhancing the cerebral blood flow. So it is a very common question in EDIC. You need to know about that. Which of the following sedative agents is most suitable for neurocritical patients with traumatic brain injury? Midazolam, propofol, dexmedetomidine, or haloperidol? So we need a drug which helps in neuroprotection. That means it decreases the cerebral metabolic rate of oxygen. It decreases the CMRO2. It gives sedation. Should not affect the target CPP. How much is the target CPP? It is 60 to 70 millimeters of mercury. And should not accumulate in the body. Is that okay? So these are the criteria for a good sedative agent in the ICU. So midazolam is a very good agent, but the problem is that it can decrease blood pressure, it can accumulate in the body. So midazolam, although it is a very good anti-epileptic also, but it is not a preferred agent as much as is the propofol. Propofol has its own sets of problems like hemodynamic instability. Then there is a syndrome known as propofol infusion syndrome. And so although these are the problems, but still we can use. Any problems with dexmedetomidine, anyone? Can you tell me what could be the possible problems with dexmedetomidine in its use for TBI?
Sedation is not very adequate.
Okay. Anything else?
Hypotension.
Hypotension is not a major problem with dexmedetomidine, but you understand that it is an alpha 2 adrenergic agonist. So there is a major problem that, okay, BP it can lower, but it can cause bradycardia. It is known to cause bradycardia, so much so that you will not realize that if this bradycardia is because of the brain injury and cerebral edema, or it is because of the agent, the drug itself. So, the dexmedetomidine, because it decreases the mean arterial pressure, there are possibilities that it might reduce the cerebral perfusion pressure as well. Although there have been some studies which show that dexmedetomidine may cause vasodilatation, cerebral vasodilatation, and it can lead to increased ICP also. So dexmedetomidine is not a favored drug. And then yes, it does not have, as somebody said, lack of reliable sedation. Sometimes it causes too good sedation, sometimes it doesn't cause a good sedation. Then the patient may have problems when you are weaning off the patient from dexmedetomidine. It can lead to rebound hypertension. So some people can bleed and have an intracerebral hemorrhage after stopping dexmedetomidine. And because it tends to get accumulated in the body, there are chances that it can uh, accumulate and cause more problems later on. So it may be used in mild to moderate cases of traumatic brain injury, but in severe TBI, where we do not want much of the problems with the cerebral perfusion pressure, we do not want certain drugs like this. We do not want deep sedation in these patients. So the only effective answer here, it is propofol. Now, propofol is actually the preferred agent for sedation in neuro ICU, specifically for traumatic brain injury. But it has its own set of problems like PRIS. PRIS is propofol infusion syndrome. So when we are talking of PRIS, we need to understand that it is rare, but whenever the patient who has been given high dose propofol, including all patients, including the patients of TBI. So, what are the risk factors? Number one is when the propofol dose has been given more than 4 mg per kg per hour for more than 48 hours. So, this is the number one factor for PRESS. Number two is basically patients who require long-term sedation. For example, the ones who have long sedation, for example, status epilepticus. So if you give them, then there are chances that these patients may develop PRESS. And then, of course, sometimes what happens is these patients are in sepsis, and we understand that propofol is made in the fat solution. So there are chances that these patients can develop uh, fungal septicemia, and of course increased triglycerides can lead to pancreatitis, and there are so many other things. It can cause rhabdomyolysis also, propofol. But anyways, as the time, it has stood the test of time, and under less than 4 milligram per kg body weight per hour doses, it has been found to be an excellent drug to sedate the patients with, even with severe TBI. So propofol is good. Why it is beneficial? Because it allows for rapid titration. So you can increase and decrease, and the metabolism is very quick. Neuroprotection is also there because it reduces the metabolic rate of brain, its oxygen requirement. It lowers the ICP, and careful monitoring is important to avoid hypotension and propofol infusion syndrome. Midazolam has a problem with accumulation, and dexmedetomidine has a lack of ICP lowering effects. In fact, it can cause deep bradycardia, which can lead to masking of cerebral edema sometimes. A patient is diagnosed with Guillain-Barré. We will discuss all of them. I'm just brushing you up with the type of questions you can get in EDIC. Some people just fear that, oh, EDIC will have so difficult questions. No, they just have usual questions, the routine things that you do in the neuro ICU. A patient is diagnosed with GBS. What is the most appropriate first line treatment for such a patient in the ICU? High dose corticosteroids, IVIG or plasma exchange, IV cyclophosphamide, uh, or subcutaneous methotrexate. Anyone?
B.
Okay. What about A?
The exturbase is usually it's contraindicated.
Yes. So nowadays, steroids, they are not indicated at all. Although people are still giving, I don't know why, but then um, it is uh, it is not indicated any longer. So what we would like to see is that the patient is started either on IVIG or plasma exchange, plasma pheresis, or a combination of both immediately. So we understand that GBS is basically an acute immune mediated. So every word is important. Immune mediated polyradiculoneuropathy. Is that okay? So it leads to rapidly progressive symmetrical weakness plus variable sensory involvement also. Sometimes people can have tingling sensation in their legs. Plus, very less books mention it, but these patients can have ophthalmoplegia. So when you look at them and you try to see the range of motion of their eyeballs, you can find that they have ophthalmoplegia along with. What are the agents which are usually responsible? So it usually happens after some infection. Okay, so molecular mimicry or something like that is the basic root of cause. So which are the main infections that can cause it? Basically any common cold like upper respiratory infection, viral. Which viruses? EBV can cause, CMV can cause, even mycoplasma pneumonia is also included in that. And then second is GI infections, which are Campylobacter. So these are the most common infections that can cause. So GBS per se has 3-4 types. Can anyone tell me what types of GBS is usually seen? So number one is AIDP, which is acute inflammatory demyelinating. So it is a demyelination, diffuse demyelination. The antibodies, they attack the neurons and take away their myelin sheath. So polyneuropathy. Then there is a condition known as AMAN, which is acute motor axonal, very poor prognosis, neuropathy. Then there is a variant which is almost AMAN but with sensory involvement, that is acute motor and sensory axonal neuropathy. Last but not the least is the Miller-Fisher variant. Sorry, Miller-Fisher variant. Can anyone tell me Miller-Fisher variant has what triad?
Ataxia, areflexia, and ophthalmoplegia.
Wonderful. So, ataxia, areflexia, and as I was mentioning, ophthalmoplegia. Oh. Okay. So, what are the symptoms for GBS? Anyone? So, it's a progressive symmetrical ascending limb weakness. So, there is a progressive symmetric ascending kind of weakness. Second is areflexia, sensory symptoms plus minus. Cranial nerve involvements. Which is the most common cranial nerve involved in GBS? Facial nerve. Okay. Then is autonomic dysfunction. So patients, they have tachycardia, labile BP, arrhythmias can happen, paralytic ileus can happen, and urinary retention is a very common feature. And the sixth is respiratory failure due to respiratory paralysis. How do you diagnose GBS? Anyone? Is there any criteria to diagnose GBS? Yes, there is. It is known as Brighton's criteria. So there has to be a progressive weakness in more than one limb. There has to be areflexia, and the duration for this has to be less than 4 weeks. Okay, this is Brighton's criteria. And then followed by this, what investigation is the most important investigation is CSF analysis. So what do you see? You see albuminocytological dissociation. So what will you see is proteins will be elevated and cells will be not as much elevated. So proteins are elevated, but the total count is almost okay. Then further on, nerve conduction studies are important. What kind of waves do you see in nerve conduction study in GBS? Prolonged F waves, very important. Prolonged F waves, and you can find conduction blocks here and there. So conduction blocks happen, demyelination leads to conduction block, and there is slow conduction velocity. The worst form of GBS, that is the axonal form, it has amplitude reduction also. Are there any antibodies identified for Guillain-Barré? Anyone? So there are two set of antibodies, anti-GM1 and anti-GQ1B. So GQ1B is for Miller-Fisher variant. Why are these important? They can be asked in the true and false statements. So knowledge can get you some marks. It is not that if you don't know them, you'll lose something. But if you know, there are chances if there are any true and false statement, then you can make a good answer. Okay. So you all are preparing for EDIC exam. So you need to know what are the criteria for ICU admission of GBS. Anyone?
Respiratory compromise.
Okay. So,
and then if they're also having an autonomic dysfunction, yeah.
So, how do you assess the respiratory compromise?
Yeah, you will by clinical monitoring, you will and monitoring, including doing ABG. You know, clinically, by the time you see them having respiratory distress and maybe slowly having a hypercapnia, you know that it's time to support ventilation.
Correct. So that is a very scientific approach. Good. The most commonly used clinical method for assessing a patient of GBS is single breath count. So you tell them to count with you from 1 to 100 in a single breath. And you start counting by yourself also. And then you will see that the patient, if it is single breath count is less than 20, this patient will definitely get intubated. So this shows that the patient has lost the vital capacity. So vital capacity monitoring and bedside PFT, this is bedside PFT. And you need to do it serially. Okay. So this is very, very important for us to know that the patient may have a respiratory paralysis, which is the most common indication for ICU admission. Rest are labile blood pressure, rapidly progressing weakness in less than 24 hours, and of course, people who have bulbar dysfunction, because they will start speaking in nasal twang, and if you do not put a nasogastric tube or intubate them, they will aspirate and they will die. So that is very, very important for us. So what is the treatment? What is the treatment? Number one, it is IVIG or plasmapheresis or both. No steroids. And of course, DVT prophylaxis, very important. Early intubation, very important. Okay. So the answer here is IVIG or plasma exchange. So Guillain-Barré syndrome, immune-mediated polyneuropathy affecting the peripheral nerves. IVIG and plasma exchange, they reduce the severity of disease and improve the recovery time. Steroids are ineffective in typical GBS and they are not recommended. The problem is antibodies, and the treatment is to take away these antibodies with the help of either IVIG, which binds to them, or by plasmapheresis, which cleanses them out. Is that okay? Clear about GBS?
Yeah. Thank you,
Great.
sir.